Good morning. I am Opeyemi Ojo, a student of the Psych Mental Health Nurse Practitioner Postgraduate Certificate Program of the University of Texas, Rio Grande Valley. Today I will be presenting a case study and working through a diagnosis and treatment plan. The case study is that of Betty Drucker, a 76-year-old Caucasian female who had experienced sad mood, diminished interest in pleasurable activities, difficulties in concentration and word finding, excessive worries about her finances, and feelings of insecurity when interacting with others. She had also lost 7 pounds in 2 months and experienced difficulty sleeping. Her physical exam depicted a depressed, anxious mood and sad affect, forgetfulness, and preoccupation with her finances. Her mini mental state examination score, that's the MMSE, was 24, and CT scan of head revealed pronounced periventricular and subcortical white matter hyperintensities. Ms. Drucker had hypertension, hypolipidemia, and a history of coronary occlusion with stents placed. She was taking hydrochlorothiazide, olmesartan, atorvastatin, and low-dose aspirin. She had also smoked half a pack of cigarettes per day for 30 years. Based on Ms. Drucker's symptoms, she has major depressive disorder and mild neurocognitive disorder. So, major depressive disorder, I would say MDD throughout the course of this presentation, and mild neurocognitive disorder, I would say MND throughout the course of the presentation. We'll go into how these diagnoses were derived in the next few slides. We would compare the DSM-5 diagnostic criteria with Ms. Drucker's symptoms and decide if she meets criteria based on her symptoms. To meet the DSM-5 diagnostic criteria for MDD, 5 or more of the symptoms will be present for at least 2 weeks, nearly every day or most of the day. And as we can see, Ms. Drucker's symptoms have been present for 2 months. So let's go through the symptoms. Depressed mood, that's present. Significantly diminished interest or pleasure in activity, that's present too. Significant weight loss, she had lost 7 pounds. Insomnia or hypersomnia, she had difficulty sleeping. Difficulty concentrating, thinking, or indecisiveness, that was present. Feelings of worthlessness, that's absent. Psychomotor agitation or retardation, that was present. Thoughts of suicide or death, that was absent. At least either depressed mood or loss of interest or pleasure in activity must be present. And with Ms. Drucker, actually both were present. Symptoms caused functional impairment. Yes, she had reduced social interaction. She stopped going to weekly card games and senior citizen center. Not due to substance or medical condition, that was not present either. So in total, she had 6 of the symptoms present for 2 months, which establishes the diagnosis. To meet DSM-5 diagnostic criteria for MND, evidence of modest decline from previous level of performance in one or more cognitive domains, either subjectively or through neuropsychological testing or clinical assessment, must be present. In this case, she had difficulty with word finding and forgetfulness. Also, her MMSE was 24. Symptoms do not interfere with capacity for independence in daily activities, although greater efforts, compensatory strategies, or accommodations might be needed. Ms. Drucker dropped out of weekly card games, but no reports of impaired general functioning. and her symptoms are not in the context of delirium and not better explained by any other mental disorder. And there is no dementia either. Depression usually coexists with cognitive impairment in the elderly. So it is not uncommon to find people this age present with both. This patient had a history of hypertension, hyperlipidemia, coronary artery disease, and smoking. Her CT findings coupled with her history all suggest some vascular etiology to her symptoms. Although current symptoms suggest MDD and MND, she most likely also has early stage vascular dementia or even Alzheimer's, but other forms of dementia like Lewy body, Parkinson's, or frontotemporal dementia is highly unlikely. Mild neurocognitive disorder is often perceived as a prodrome to dementia. Typically, the rate at which these individuals progress to Alzheimer's disease is approximately 10 to 15% a year, and it is associated with progressive loss of function. However, diagnosis is not stable, as some patients may convert to Alzheimer's or revert back to normal functioning. In terms of management, Ms. Drucker should be on medications, especially because of the extent of her symptoms. According to the literature, escitalopram, which is also called Lexapro, a selective serotonin reuptake inhibitor, SSRI, is well tolerated and effective for the treatment of MDD. We will start Ms. Drucker on Lexapro at 10 milligrams daily after explaining to her possible side effects. Furthermore, cognitive behavioral therapy has been proved to be equally effective as SSRIs in the treatment of depression, according to research. This option would also be given to Ms. Drucker to consider. For the mild neurocognitive disorder, there were no established treatments at this time. Treatment is aimed at early recognition and management of risk factors. Since Ms. Drucker has a history of hypertension, hyperlipidemia, coronary artery disease, and smoking, we plan to work on a healthy diet, exercise, and compliance with medications. Plan is to follow up in 4 to 6 weeks to determine if medication needs to be titrated, continued, or discontinued. Here are my references. Thank you.